Hi guys, and welcome to our model on the stomach. So we're talking about the stomach, and we'll make mention to the gross anatomy of the stomach. Then we'll talk about the histology, and then finally the embryology of the stomach in this model. Stomach is a pliable, elastic, circular organ that is found within the abdomen, which makes it one of the important viscerals to talk about in this model. It is one of the aspects of the GIT alongside the small intestine and the large intestine found in the abdomen. And if you're comparing the rest of the GIT in the abdomen to the stomach tends to be described as the most dilated part of the GIT. As you can see in the image below, you can see how circular it looks. And you can see it being continuous with the rest of the GIT, in this case, the small intestine shown here. What exactly do we have? The stomach. We have the stomach for storage of food, what we call reservoir of food. We have stomach and the acid of the stomach to soften the food and mix the food with digestive juices. The digestive juices within the stomach, like the hydrochloric acid, pepsin, and the likes, help in breaking down food into its the minute form. We have gastric glands producing hydrochloric acid. Also, production of mucus is found within the stomach, and as well within the stomach, alcohol, water, and salt tends to be absorbed. But it's not the primary set of absorption of each of these different substances, but it does perform some form of absorption alongside the small intestine when we talk about food. Jumping into the gross anatomy of the stomach, let's talk about its location. Stomach is said to be located in the lower upper quadrants. Then that's when we talk about the quadrants. But when we talk about the regions, the stomach tends to span the epigastric region to the left hypochondrial and also a bit of the umbilical region as shown in the drawing I'm outlining here. And pain within the epigastric area, within the left hypochondrium or within the umbilical area could signify a pathology that is affecting the stomach. Stomach is about 25 centimeters in length, just as most of the other organs within the GIT. The duodenum, alongside the esophagus, are also 25 centimeters in length. Its capacity is about 1 to 2 liters. It could store about 1 to 2 liters of food or fluid within the stomach. That's why when we talk about the shape of the stomach tends to differ based on its fullness and posture. So, in if the stomach is empty, the shape of the stomach is described as being J-shaped, whereas if the stomach is distended, if it is filled up with food or fluid, the stomach tends to be described as being piriform in shape. The stomach has two ends to it, and each of these two ends are guarded by what we call sphincters. So sphincters are guard pathway or doorway that separates a particular aspect of the GIT from the other, or if they talk about the urinary system, separating one part of the urinary system or one part of the GIT from each other. So in the case of the stomach, we have the cardiac sphincter and the pyloric sphincter. We'll talk about each of these sphincters next. The function of the sphincter is just to separate contents and a part of the stomach from structures proximal to it and structures distal to it. Cardiac sphincter is a physiologic sphincter. It's physiologic meaning that there's not actual anatomic structure that tends to form that guard or form that doorway. The physiologic aspect of it is the fact that the sphincter is formed by the presence of the diaphragm and the way in which the diaphragm tends to interact with the gastroesophageal junction. It is the sphincter that tends to guard between the esophagus and the stomach, so it limits influx or reflux of gastric contents into the esophagus, and it also limits the inflow of esophageal contents into the stomach. But most importantly, is the first, in the sense that the gastric sphincters tend to the cardiac sphincters rather tends to help in preventing reflux of gastric contents into the esophagus. The second is the pyloric sphincter. Now, this is an anatomic sphincter, meaning that there's an actual structure that forms the guard around the stomach to form a doorway or sphincter. And the pyloric sphincter is a sphincter that tends to separate the stomach from the duodenum. It helps in guarding the entry of substances from the stomach to the duodenum. And as a result, it helps in moderating the movement of fluid or food through the GIT. The stomach has two major surfaces. These are the anterior and the posterior surfaces. The anterior surface is continuous with the anterior surface of the esophagus proximally, and it is covered by a layer of a peritoneum called the anterior layer of the mesogastrum. Then the posterior surface is also continuous with the posterior surface of the esophagus. It is also covered by the fair share of mesogastrum, but particularly the posterior layer of the mesogastrum. Remember that the stomach is an intraperitoneal organ, so both its anterior and posterior surface will both be covered by by peritoneum. In this case, we call that peritoneum the mesogastrum. The stomach has borders. The borders of the stomach are referred to as curvatures. We have two major curvatures of the stomach. The lesser curvature, which is the curvature that is shorter. We'll talk about that very soon. And then the greater curvature, the longer curvature, as shown here, as the most lateral curvature in this picture. Let's talk about the curvatures in the next slide. The greater curvature of the stomach is the longer and convex curvature. It's found on the lateral border of the stomach. It forms the lateral border of the stomach. It's convex and it is longer compared to the lesser curvature, hence the name. It is attached to the omentum called the greater omentum, and it contains some blood vessels that tend to run within it. The blood vessels that are found in the greater omentum running along the greater curvature will be the right and left gastroepithelial vessels, what we call right and left omental vessels. For the lesser curvature is shorter, it is concave, and it forms the right border of the stomach. This one is attached to the lesser omentum. It's connected to the liver through that lesser omentum, the same way which the greater omentum, greater curvature is connected to the transverse colon through the greater omentum. For the lesser curvature, it contains its own fair share of vessels, what we call the right and left gastric vessels. And this is in contrast to what we see for greater curvature that contains right and left gastroepithelial or mental vessels. The stomach has four major parts. We could divide the stomach into four parts. This includes the cardia. Cardia is the part that is closest to the esophagus or closest to the proximal aspect of the stomach. Then we have the fundus. The fundus, we'll talk about the fundus very soon, and that's the area shown in yellow, in orange here. Then we have the body. The body is the largest aspect of the stomach in green. And then finally, the most distal aspect of the stomach is toward the pylorus. We'll talk about each of them next. The cardia of the stomach, like I said, is the most proximal portion of the stomach and it is connected to the esophagus ends. It is the area that contains the cardiac notch. The cardiac notch is just the area that tends to separate the esophagus from the fundus. And it contains the cardiac sphincters. The sphincters I talked about is a form of doorway or valve that separates the stomach from proximal structures like the esophagus. The fundus, on the other hand, is the most superior part of the stomach, and it's the area that reservoir or storage of food tends to occur the most. It receives a lot of food and allows for expansion of the stomach whenever it is distended of food. This is just an image showing us the different parts of the stomach again. The area outlined for us here in pink is the cardia of the stomach. You can see it is the most proximal portion, and it is the part of the stomach in connection with the esophagus in here. Then we have the fundus of the stomach here. That's the most superior aspect of the stomach. You can see it is most superior because it is extending just be above or the same level as the lower aspect of the esophagus. And it's the area that tends to have a lot of storage of food and fluid molecules because of its distension. The body of the stomach is the largest part of the stomach as shown in the image previously. It contains two major outlines. It contains the angulus insura and it contains what we call gastric ray. The gastric ray is seen whenever we cut the stomach into half and we are looking at the innermost aspect of the stomach. When we talk about the histology, I'll show you pictures of how the gastric ray looks like. In terms of the pylorus is the distalmost portion of the stomach. It is connecting the stomach to the duodenum, and it contains three major aspects. It contains the antrum, which is the most dilated aspect of the pylorus, the canal, which is a small or narrowed aspect of the pylorus. So if the antrum is the most dilated part, the canal is the most constricted part. And then we have the pyloric sphincters, which is synonymous with what we have or analogous to what we have in the cardiac, which will be the cardiac sphincters. The pyloric sphincters tend to guard and prevent or restrict flow of fluid and restrict flow of food from the stomach into the duodenum. And this is just an image of the other two aspects of the stomach. The body, like I said, is the largest part. You can see how the body takes the entire aspect of the stomach in this picture. The body member also contains two aspects. There's what we call the angular insura. Angular insura is at this point here. It's a portion as an aspect of the lesser curvature that tends to divide the body into two parts. The upper part called the cardiac portion, and the lower part called the pyloric portion. Just for you to note that. And when we cut open the stomach, would also tend to see the rugae. Finally, we have the gastric, the pyloric region, pylorus. The pylorus or the pyloric region contains different areas. It contains the pyloric antrum, which is the wider aspect. You can see that in orange. Then we have the pyloric canal. Pyloric canal is shown here in green. It's the narrow aspect, and then we have the pyloric sphincters, which guard against the inflow and outflow of substances from the stomach into the Let's talk about the relations of the stomach. When we talk about relations, the remaining structures found in front, behind, lateral to, or beside the uh, given structure. In the case of the stomach, the anterior relations of the stomach will include structures like the diaphragm, the liver, the spleen, and the anterior abdominal wall. So you can see in the image just directly at the side, the anterior abdominal wall is going to cover the entire aspect of the abdomen. So it is going to be most of the anterior relation for all the structures or all the viscera of the abdomen, the stomach included. Aside the anterior abdominal wall, you can see the liver also covering the stomach anteriorly, so it's an anterior relation. You can see the spleen covering the stomach anteriorly is also an anterior relation, but unshown here is the diaphragm. The diaphragm tends to form a dome and it tends to cover most of the structures, including the liver, alongside the stomach and the spleen. So it covers everything at this point. So I'm just drawing an outline of the diaphragm. So these are the anterior relations of the stomach as shown here. The posterior regions of the stomach. The posterior regions of the stomach include a bunch of different organs, and these organs in combination, we refer to them as the stomach bed. So we can say the posterior relations of the stomach are also called the stomach bed. Between the stomach bed and the stomach is a very huge space. That space is called the lesser sac. So the lesser sac tends to separate the stomach bed, which are the posterior relations of the stomach, from the stomach itself. So what are these structures forming the stomach bed? They include the diaphragm as the posterior part of the diaphragm, the left kidney, the left suprarenal gland, the pancreas, the left colic flexure, transverse mesocolon, and the spleen. All of these structures are all stomach bed structures. They're all posterior relations of the stomach. And this is a likely essay question for you. So please do note one of the questions they'd like to ask you would be an essay question. You could just ask you to list organs that form the stomach bed. And they just want to list the posterior relations of the stomach as shown here. So you can see stomach is outlined for us here in white, but behind the stomach, you see the spleen, you can see the left kidney, you can see the left suprarenal gland or adrenal gland here in orange. You can see the pancreas, which forms the majority of the aspect of the posterior of the stomach bed. We can also see the splenic artery, not listed here, but splenic artery also there. We could see the colic flexure. This is the left colic flexure being a part. And we could see the transverse mesocolon. This is the transverse mesocolon also being a part. And then finally, the diaphragm forming aspects of the posterior aspect of the stomach. This is the better image showing us the stomach bed, and what you notice that just directly behind the stomach is this space. This space is called the lesser sac or the omental bossa, and behind that you have all the structures that are plastered to the posterior abdominal wall. These structures will form the stomach bed. So they include structures like the pancreas, you shown here, the spleen in this image, the kidneys down here, and then some other structures as mentioned before, like the splenic artery, splenic vein, transverse colon, but not sure they're already in this image. What's the arterial supply to the stomach? The stomach is supplied by a bunch of different arteries that come from different sources. These arteries are four in number. They include the short gastric artery. So short gastric artery is involved in supplying the fundus of the stomach. Then we have the right and left gastric arteries that we mentioned before. These are arteries that tend to run on the lesser curvature as shown here. So the arteries running around this region. They supply the body alongside the lesser curvature. And then we have the right and left gastroepiploic artery. So arteries that tend to run at the greater curvature in the greater omentum, and they will supply that greater curvature alongside the body of the stomach. And then finally, we have some arteries that are not necessarily frequently seen, but are also important to note. And this would be the posterior gastric artery. Posterior gastric artery tends to supply more of the posterior aspect of the body of the stomach. This is just an image of the arteries of the stomach. Again, you see the left gastric artery, short gastric artery coming from the splenic artery, posterior gastric artery, the left gastroepiploic artery, uh, the right gastroepiploic artery, and the right gastric artery. All of these are all arteries supplying the stomach, whether the body, the fundus, the lesser or greater curvature, or the back of the stomach. Let's talk about venous drainage. Venous drainage to the stomach. All veins of the stomach, all veins draining blood from the stomach will be ending up at the splenic vein and the superior mesenteric vein. And the combination of these two would give rise to the portal vein. So all venous blood drained from the stomach would eventually end up at the portal vein. And from there, the portal vein is going to be going to the liver for detoxification. Let's talk about the lymphatic drainage of the stomach. Lymph in the stomach tends to be drained from different regions of the stomach. Usually, four middle regions are important to note. The first region is at this point from the fundus of the stomach all the way down to the part of the body of the stomach. Then we have the major aspect of the body of the stomach being divided into area B and region C. And then finally, the area we know as the pylorus is the area D. Now, each of these areas are going to be draining lymph with different lymph nodes. Area A, for example, the fundus and a part of the body will drain into the pancreatical splenic nodes, whereas area B, because it's closer to the lesser curvature, will drain to the left gastric nodes. Area C, because it's closer to the greater curvature, will drain to the right gastroepiploic nodes. And then finally, area D will drain to the celiac node. So these are just different lymph nodes draining different aspects of the stomach as outlined in this image. But nerve supply to the stomach, the nerve supply of the stomach is coming from the autonomic nervous system because the stomach is a visceral structure. Because it's going to be supplied by the autonomic nervous system, will have sympathetic and parasympathetic supply to the stomach. Sympathetic supply to the stomach comes from the celiac plexus and some form of vessels from the splenic nerves, whereas the parasympathetic supply to the stomach comes largely from the vagus nerve. Let's talk briefly about histology. The GI tract alongside the stomach is a hollow tube, and the fact that it's a hollow tube will mean that it's made up of a lumen and walls surrounding the lumen. So the stomach is not any different. Just like every other aspect of the GIT, the stomach is made up of a lumen, which is the space, and then the wall surrounding that space is made up of four layers of tissue. These layers of tissue includes from inside to outside. We have the mucosa. The mucosa is the area shown here, well folded up mucosa. Then we have the submucosa. Submucosa is just the area beneath the mucosa, and this is the submucosa at this point. Then we have the muscularis externa. The muscularis externa is this large aspect of the stomach made up largely of muscles. And then we have the serosa. Serosa is just a small, tiny aspect of the stomach uh, that is protective of its external surface. So serosa is the most outer aspect of the layers of the stomach, whereas the mucosa is the most inner aspect. Just about each of these layers of the stomach or tissues histologically for the stomach in the next set of slides. So this is another image showing us the stomach in terms of histology. See that the innermost layer of the stomach is the mucosa, followed by the submucosa, then the muscularis externa, and then the subserosa or the serosa layer, which is the outermost layer. The mucosa of the stomach is the innermost layer. It is composed of two sublayers, usually three sublayers, but most times we talk about two. This includes the epithelium, a connective tissue layer known as the lamina propria, and then a small sized muscle area called the muscularis mucosa. Very important to remember that the mucosa of the stomach is lined by the epithelium or simple columnar epithelium. This is distinct from what we see in the esophagus. In the esophagus, the epithelium of the esophagus is lined by stratified squamous non-keratinized epithelium. For the stomach, simple columnar epithelium. And this form of epithelium tends to be continuous from the stomach, small intestine, and large intestine, all the way down to the anal canal. One important thing to note is that macroscopically, the mucosa of the stomach will be identified by the presence of folds. These folds, I talked about them already, are found largely in the body of the stomach and they're known as gastric rugae. But when we dig deep and look at the microscopic view of the mucosa, these rugae are further broken down into invaginations. These invaginations are regarded as gastric pits and gastric glands. So gastric pits are the depressions and gastric glands are just the cells that are lining those depressions and what they secrete. The pits and the glands contain a number of different cells. We'll talk about those cells in the next slide. First of all, this is the macroscopic view of the body of the stomach, and you can see the gastric folds, the gastric rugae directly shown in this image. And what you notice is that there's a change in macroscopy of from the way in which the esophagus looks like internally as compared to the stomach. The esophagus looks more smooth compared to the stomach. Once you drop down to the stomach, there's a change. Usually, the junction where there's a change from the esophagus to the stomach is known as the Z line histologically, or we can call that the gastroesophageal junction. Let's talk quickly about the different cells we have in the gastric pit and the gastric glands. Gastric pits are microscopic invaginations of the stomach found in the gastric rugae. For the cells we have in the gastric pit of the stomach that they eventually give rise to glands, we have the surface mucosal cells. Surface mucosal cells are the cells that are going to be lining more of the upper part of the stomach and not necessarily the invaginations. As we go down, we have what we call the neck cells. These are the neck cells here. Then we have the stem cells. Stem cells are just directly after the neck cells. We have them here. Then finally, we have some lower cells that are involved in actual secretion of substances, like the parietal cells. Here, the chief cells. Chief cells are cells that are found at the lowermost part of the stomach, at the pit. Then we have other cells that we call endocrine cells. Enteroendocrine cells include cells like the G cells, D cells, the enterochromaffin-like cells, and then enterochromatin cells. So these are all endocrine cells. One important thing to note about each of these cells, so surface mucosal cells, for example, lines the lumen and then the gastric pit. It's involved in secreting thick, adherent, highly viscous mucous layer, and it is rich in bicarbonate. This helps in neutralizing some of the acid being produced by the stomach. The neck mucosa cells, on the other hand, just lines the neck of the gastric glands, and it also secretes alkaline fluid, but this alkaline fluid is less compared to what we see from the surface epithelial cells. Then we have the stem cells. Stem cells are found at the junction between the pit and the gland. They are cells that tend to be involved in replacing surface mucosal cells if they die, and they tend to migrate all the way up. Um, and then differentiate, they can differentiate into secretory cells of the gastric glands later on. Then we have the parietal cells. Parietal cells, I said, are cells that are found usually at the middle part of the gastric glands. They are involved in the production of hydrochloric acid. That's their major function. And in order to do that, they will be making use of high levels of carrier proteins and channels to be able to pump out hydrogen and chloride ions. One other thing to note about the parietal cells is the fact that aside hydrochloric acid, they are also involved in the production of intrinsic factors. Then we have the T cells. T cells are found at the lowermost portion of the gastric pit. They tend to be involved in production of digestive enzymes like pepsin and gastric lipase. G cells are involved in the production of gastrin, hence the name G cells. D cells are involved in the production of somatostatins. Enterochromaffin cells are involved in the production of serotonin, whereas the enterochromaffin-like cells are involved in the production of histamine. So just note each of them. So G produces gastrin, D cells produces somatostatin, enterochromaffin-like cells produces histamine, and then enterochromaffin cells produces um, serotonin. So you could use this image in remembering each of the cells and what they're involved in secreting surface cell secretes alkaline fluid containing mucin. Mucous neck cells also produce alkaline fluid, but that is less alkaline compared to the surface cells. Sometimes we say it's acidic in form, but it's usually just alkaline, but less alkaline. Parietal cells are involved in production of hydrochloric acid and intrinsic factors. Chief cells produces pepsinogen and gastric lipase, and then the endocrine cells produce in hormones that gastrin, somatostatin, histamine, and serotonin. The second layer of the stomach histologically is the submucosal layer. It is the layer beneath the mucosa. It's a layer that is composed of dense connective tissue that contains collagen and elastic fibers. It contains a lot of vessels. It is highly vascularized. And most importantly, they are a form of specialized nerve cells found in the submucosa called the Meissner's plexus. The Meissner's plexus, alongside another form of set of nerves, tend to form what we call the endocrine or the nervous system of the GIT, the enteral nervous system. The third layer of the stomach histologically is the muscularis externa. It is the thickest layer. It's composed largely of smooth muscles. There are three major fully defined smooth muscles that we find in this muscularis externa layer. This includes the inner oblique muscle, the middle circular muscle, and then the outer longitudinal muscle. This arrangement is not really seen elsewhere in the GIT. It's largely tends to be confined to in the stomach. So the muscular intestinal is kind of very unique in the stomach as compared to other aspects of the GIT. Very importantly, the same way which we have specialized nerve tissues within the submucosa, we have also have specialized nerve tissues within the muscles, particularly within the first two muscles, and this is called the Alpha plexus. Alpha plexus compared to the Mesenteric plexus is involved in movement of the muscles, so it's involved in stimulating peristaltic movement of the muscularis externa. Whereas the Mesenteric plexus we mentioned in the submucosa is more involved in stimulating glands to secrete different form of secretions within the stomach. The last layer of the stomach histologically is the serosa, it's the outermost layer. It's the layer that is in continuation with the peritoneum, so it is made up of simple squamous epithelium and lines the entire aspect of the stomach externally. Let's talk quickly about embryology. The stomach tends to develop from the distal part of the foregut at around the fourth week of intrauterine life. We'll talk about this development in a bit. So this is the picture of the gut. The gut begins from the an area called the stomodium and ends at the area called the proctodium. The stomodium and the proctodium are practically openings of the mouth and the anus in the fetal structure. And the organ that tends to connect those is what we call the gut. The gut is further divided into three parts. Usually tend to call the first part the foregut, and then the second part the midgut, and the third part the hindgut. And each of these are going to be involved in the formation of the entire GIT. The foregut will be used in the formation of the esophagus alongside the trachea, a part of the trachea and the lungs to emerge from the foregut, what we call the lung bud or the respiratory diverticulum. I'm outlining it here. But the posterior aspect of the foregut becomes the esophagus, and then the distal portion of the foregut becomes the stomach and other structures. So we are going to focus on the aspect of the foregut that forms the stomach, which is this distal portion right here. So during the fourth week, a slight dilatation occurs at the lower aspect of the foregut. That slight dilatation is going to form or is going to be indicating the formation of the stomach. That area is the primordial of the stomach. It's the site where the stomach is going to form. So this dilatation first appears as a fusiform enlargement. So it appears as if, let's say it was initially this size, then from being a straight line tube or of the foregut, we have this fusiform enlargement, something like this we can call an outpouching. That outpouching is this the perimeter of the stomach, and it becomes it's found at the distal aspect of the foregut and becomes initially oriented in a median plane. And subsequently, during the second week, the dorsal border of the stomach will now start to grow. So what I mean by that is that though this that's one in a fusiform fashion, then the back, this part that is pointing forward, will keep on growing larger and larger, more posteriorly. So we have it going from that to something like this. That's one where the dorsal border will grow faster than the ventral border. So we have more of an outpouching from the dorsal side compared to this. So this is the dorsal side of this of the foregut is the ventral side. The dorsal side will grow faster than the ventral side. So we have this sac-like appearance around the next 2 weeks, around 6 week post development. Then what happens is that as this is growing, as the foregut, this aspect of the foregut is growing, that aspect is now suspended by the peritoneum, what we call the mesogastrium, ventrally and dorsally. So ventrally and the anterior surface, we have a ventral mesogastrium suspending it. In the posterior surface of the stomach, we have the dorsal mesogastrium suspending it. And as this growth continues, as the stomach continues to enlarge, we have the stomach now starting to rotate around its longitudinal axis. So it rotates in a clockwise direction and it rotates about 90 degrees clockwise direction. This is extremely important to remember. The rotation of the stomach is 90 degrees to the clockwise direction along the longitudinal axis. And this is very important because of your MCQ questions and because of having to understand how the different aspects of the stomach would end up being the adult structure. So what happens when the stomach rotates 90 degrees clockwise? So what happens is that the initial ventral border of the stomach becomes the right, turns becomes the right part of the stomach. The initial dorsal border becomes the left, it moves to the left. The left border becomes the ventral surface, becomes anterior. The right border becomes the dorsal surface, becomes posterior. The cranial end of the stomach will descend a bit because that rotation is going to also make the stomach to turn on itself. So the cranial part will descend slightly, it will drop down slightly a little bit to the left and slightly inferiorly. And then the caudal end of the stomach will tend to descend to the right and then go a little bit superiorly. And then finally, the ventral mesogastrium, because the stomach is turning right 90 degrees clockwise, the ventral mesogastrium on the anterior surface of the stomach will be moved together with the left border of the stomach, and then eventually we'll move to the left. Dorsal mesogastrium on the other hand will move to the right. So this is practically what happens. So please, in order for you to memorize this, in terms of what happens once the stomach rotates 90 degrees uh, clockwise in the longitudinal axis. So this is an example of the stomach and its uh, rotation. You see how the stomach is possible initially. This is the ventral surface, this is the dorsal surface here. All right. Then we have the right border and the left border. All right. Let me label that again so it's a bit more visible. So we have the ventral surface here. The dorsal surface is at the back, somewhere around here. Then we have the right border and the left border. So just pay attention to what happens. Initially, you notice that the dorsal border tends to increase in size more. And as they increase in size, we have a rotation occurring. You can see that rotation already beginning to occur at this stage. You have a clockwise rotation that you're running down from 12 o'clock to 3 o'clock. So a clockwise rotation occurring. And that clockwise rotation will make the ventral border to become right. All right, to make the right to become dorsal, make the dorsal border become left, and then make the left to become ventral. So that's what happens due to the rotation. That's practically what was explained there. Besides that, the cardiac, the cranial end of the stomach will drop down a bit. You can see it's initially up, it's dropping down a bit, making sure to form that front base of the stomach that we tend to know. And then the caudal part of the stomach will ascend a little bit upward and go to the more to the right. So this one moves to the right more, this one moves to the left more. That's practically what happens during the period of the stomach. Let's talk about derivatives. It's not going to be complete if you don't mention the derivatives of the stomach from its fetal structure to the adult structure. So, starting with the ventral border. The ventral border of the stomach will now become the lesser curvature. All right. The dorsal border will become the greater curvature. That's important to note. The left border becomes the anterior surface of the stomach. The right border becomes the posterior surface of the stomach. The cranial end becomes the cardia of the stomach. I mentioned the cardia of the stomach being the part connected to the esophagus. The caudal end becomes the pylorus of the stomach. The ventral mesogastrium becomes the lesser omentum, and then the dorsal mesogastrium becomes the theta omentum. So this is the adult derivative of all the structures I mentioned in relation to the development of the stomach. Let's end this model by talking about clinical significances. So let's talk about two major clinical significance of the stomach. That's gastric ulcer and gastric cancer. The gastric ulcers are practically defects within the mucosa or epithelial lining of the stomach. As you can see, majority of the aspect of the stomach contains folds, but when you start to have a breach in the epithelium or a breach in the mucosa of the stomach, in which there's the lesion eating all the way down to the submucosa and even to the muscularis externa, we call that an ulcer. So this is an example of a gastric ulcer. The commonest site of gastric ulcer occurring usually at the lesser curvatures around this part. This is the commonest site, although it's not shown here, but this is the commonest site of ulcer occurring. The reason is because we have a lot of concentration of acid around this area as compared to the rest, and that's because there's very poor amount of folds in the lesser curvature. Instead of having a lot of folds, we have what we call a gastric canal. Most of the folds are longitudinal. As a result, it allows for easy tracking of gastric acid along this area, and then ulcers forming from there. So this is the live picture of the gastric ulcer. You can see it due to endoscopy. You can see how the ulcer is forming, and you can see how fluid is accumulating within the ulcer. This is what will cause the gastric pain and make someone to be complaining of serious heartburns and requiring the use of proton pump inhibitors like omeprazole and the likes. This is another ulcer. This one is even deeper than the initial one. You can see it's in this with different fluids present there. The last aspect of this model will be on the gastric cancer. Gastric cancer are just abnormal growth of the epithelial structures of the stomach. It could be epithelial. It could also be mesenchymal. So you could also have the muscularis externa having excessive growth. You could have the submucosa having excessive growth. But majorly, what we tend to see is that we tend to see a gastric carcinoma being as a result of abnormal growth of the epithelial lining, not necessarily the muscle layers or the connective tissue layers. And that concludes our model of the stomach.